for the records, I guess.
Yes.
Okay. Good morning, ladies and gentlemen. To start at 9 o'clock, far from the hotels, is always a challenge. So thank you all for being here. I'm Wanda Nunes de Lima. I'm working at the GRC within the Inspire team. I've been in charge of coordinating the development of data specifications for the 3 teams of Inspire. And now, all those things already done, I'm involved in the implementation and the maintenance of Inspire and its application for other policies. So putting it in place for the purpose Inspire was created. This workshop, it's, I believe, a step forward in the integration and the collaboration between the community already deeply involved in the Inspire implementation and the human health, and bringing together the environment and geoinformation within this community. And we are here today to listen to your requirements on using spatial data and to understand in a practical way how Inspire, within its legal frame, but also technical and infrastructure frame, how it can be of help to help on solving the problems that community may have in terms of information sharing and using and integrating data. So I don't want to take more time to the session. I leave the session be shared by Jiri, who was deeply involved on the, let's say, setting up of this workshop.
Thank you, Wanda. I will try to use this funny thing. Good morning, everyone. Thank you for coming to our little workshop. What I would like to... Oops. What I would like to share with you is, I would love to share, but the computer has... Okay, well, doesn't matter. So, last try. Okay. Surprise, surprise. So we have over many years been following the problem that environment policies have certain indicators. We say that key performance indicators of environment policies are health of ecosystems and crucially health of people. Measuring ecosystems health is very complicated. Understanding people's health is much more easier. So there is this Inspire directive. It has, I personally consider it quite a success, a real success in terms of getting the data to users, integrating, providing bridges, because we simply don't stop on the border, because environment doesn't stop on the border and people's health doesn't either. Inspire directive has passed. It's many years ago. It's 7 years ago, and now we are getting the very first results in terms of we are now able to run the first models. The integration of data, the way that the data is being harmonized, the usage of data is now stressing the possibility to have new ways of modeling new sorts of applications. Yeah, it's visible. We have covered the world of geospatial data in categories that allow us to provide integrated view. Integrated in terms of urban planning, which is everything from greenery to traffic, and we are able to go to facility level to understand that someone had to permit the facility. The facility had then some waste transport, and we understand it in the whole. Inspire was a huge collaborative effort, and thanks to you, thanks to the whole Inspire community, we have achieved something remarkable, and it is unbelievable involvement of all those who participated. So for the interoperability, we have common data models, encoding, vocabularies, and registers that we together have developed and standardized across the whole Europe. So why for this health and the environment workshop I'm showing this? I want to come to a point where I can just show with my finger we have already worked in the health and safety environment, because this is super important. What we have in offer from administrative units that are very important for the health statistics, where we can provide detailed information, how to link together units with administrative units, with statistical units, how to harmonize it with geographical grids, so we can show population density. Again, super important data for modeling. And we also have health statistical data already in the implementation rules. So we already have data models, we already have conceptual models, including health determinants and safety, which is not yet in the implementation rules, but it paves the way to future expansions. So Inspire is a framework directive, meaning it provides the basis for communication for further extension. Inspire already has, out of the 300,000 data sets that we have covered under Inspire directive currently, this is just 1%. We have some 3,000 data sets that are under health topic, but 3,000, I'm very nicely surprised how much data we already have. So I will stop here. I will leave the space for those who are able to provide much more detailed insight, and I will come back again with some questions at the end. So thank you so much, and let me invite let me invite Dr. Schreck, who is sorry. Okay. Technique. Okay, Mr. Schreck is head of unit for health information, and this way I'm giving you.
Yes. Good morning, everybody. I see whether I can deal with this microphone here. Do you understand me? Somehow. Okay. Yes, so good morning, everybody. Yes, indeed. I'm the head of the Health Information Unit in DG Sanko. Yes, and I'm here to explain you why we are interested in collaborating with the Inspire framework, if you so wish. But before I do that, I just want to try to explain to you what our problem is and what we try to achieve. Yeah, because indeed the question is always in how far new technical advances and new methodologies and capacities can actually help us reaching our objectives. Because in the past very often we have been the victims of technology-driven developments. Yeah, in other words, of solutions looking for a problem. Yes, and that's why now these days we are very keen first to identify actually a problem, and then to try to find the right way of addressing it. Yeah, and this is, by the way, an issue which is never going to go away. For now, for example, we have this problem with what is called big data. Yes, everybody is talking about it, and it's very difficult to make the link between this kind of solution and the problem. So, what are we doing in DG Sanko on health data? Well, we are not collecting data. We have other bodies and partners collecting the data. What we try to do is we try to develop a policy that makes sure that the health data which are needed are actually available. Yes, and that is quite complicated because on the one hand you need to identify which kind of health data are needed, and basically we are talking about two essential types of users: the research users, who try to find out what the causalities are between certain health determinants and the health outcomes, and secondly the decision makers in health policy. And if you're working at European level on health data, this is quite complicated because in the area of health, responsibility is essentially with member states. Member states are responsible for their health systems. Member states are responsible for public health. And what the European Union can do is just to complement what member states are doing in the area of health. Yeah, and then people are very often asking, so what is the difference between what you are doing in health at European level and what WHO, so the World Health Organization, is doing at international level? Because there is also a branch which is called WHO Euro, in charge of Europe in terms of health. And in this framework, in other words, between the responsibilities of member states in health on the one hand, which are fully responsible for the health of their citizens, and what WHO Euro is doing at international level, DG Sanko, the health policy makers in DG Sanko need to find their place. Yes, and essentially this means my colleagues who are in charge of operational policy try to do what cannot be done at national level or what can be done much better at European level. And for example, just to give you some examples where we think there is a very high European added value, for example, when it comes to health threats like flu pandemics, it is quite clear that infectious diseases do not respect borders, and that therefore it is essential to have a good collaboration among European member states. And this week, for example, there will be an agreement signed by the health ministers of the EU member states, which will allow the Commission to procure jointly flu vaccines. If there's a new flu pandemic, member states will no longer individually go to the pharmaceutical industry and purchase their vaccines. This is going to be done for all those who want to participate by the Commission collectively. And another area where it is very useful to collaborate at European level are rare diseases. In other words, diseases which are so rare that it isn't really worthwhile for every member state to have an infrastructure to care for the patients. It's much better to have a collaboration among several member states to pool the expertise, provide better service for those patients, and also make savings for health systems. So essentially what we need to do is to pick those areas where there's a specifically high European added value. For all the rest, it's the member states' responsibility. Now the question is, what does this mean for health data? Yeah? Which kind of data do we actually need for policy making at European level? And for which data, even if we don't really need them at European level, it is an advantage to have comparable data at European level in order to allow member states to compare their own performance with the performance of other member states. So even if they are responsible themselves for the policy, they might consider it very useful to be able to compare their data with other member states to compare themselves and to improve their system. Yes, and on the one hand, this is very useful, and as the health systems of member states are radically different from each other, we have really a very interesting garden of different health systems in Europe, which actually allows very interesting comparisons across borders if you have comparable data and if you don't compare apples and pears. So it's potentially very useful, but on the one hand very difficult to achieve this comparability of data. On the other hand, it might also be a political problem, because if it's too easy to compare, health ministers might find themselves easily in a situation where journalists point to other countries saying they are doing much better than you are doing. And this is then often perceived as a political threat. Yes, so this is more or less the overall political framework in which we operate. So we try, on the one hand, to provide comparable data at European level to underpin our European policies which we have and to measure the success of policies at EU level. On the other hand, where member states are interested in providing data, comparable data, for use in the member states by the governments of member states. Yeah, and this is all very complicated because you don't believe it, but there are lots of bodies and organizations and projects collecting health data. And as I said, what we try to do is not collecting data, but to create a sustainable, structured system to ensure that those data which are needed are actually available, regardless of who actually collects those data and for what purposes. We just want to ensure that they are available. And so we do a lot of things in order to achieve this. Yeah, and I actually have in my slides a couple of examples, but maybe before I come to that, these are the latest Council conclusions of December of last year, yeah, where the Council essentially was thinking about modern, responsive and sustainable health systems. And one of the conclusions was that the Commission and Member States are invited to establish a sustainable and integrated EU health information system. Yes, so that's basically our political mission, if you so wish. But system obviously is built from several components, and we try to establish these components. And a very important word there is also sustainable. Yeah, and that means not environmental sustainability, but in our case it means financial sustainability, because it actually costs money to collect data. And a lot of data which are used for policy purposes have been collected in the past on a project basis. Yes, and then the project closes down because it's finished. It establishes a database, and afterwards nobody knows what to do with the database. That happens very often, and we want to go beyond this. I'll tell you later how we try to do that. But essentially the point I try to make here is we have a political mandate, if you so wish, to establish such a sustainable and integrated system. And this word integrated is of course also very important, because We don't want to create new isolated data silos, and that is why we think it's important to collaborate with frameworks like Inspire, because that could have a real added value for us. Yes. Now, what we do to integrate all that? Well, first of all, we have established a so-called expert group on health information, the IGI group, which meets about twice every year. And basically, this is our forum to discuss all the health data needs which exist in the European Union at European Union level. And essentially, all the member states participate. All the Commission services which are interested participate in that, yes, for example, and we try to expand the scope as much as we can. At the last meeting, also the colleagues of DG ECFIN participated and explained, for example, how ECFIN assesses the health systems of member states to make their recommendations where you have to cut your budget in the health system. Yes, and of course that is a very important issue, and of course also depends on good data, because if you don't have good data, then ECFIN will decide to cut where it shouldn't be cut, and vice versa. So this is now a very practical consideration. Yes, and the other thing to make this more sustainable is that we invented the so-called European Core Health Indicators, ECI. In the past, when all this work on health information started, there were lots of projects, and all these projects tried to define health indicators, and there were literally thousands of different indicators defined. And there was absolutely no hope to ever turn this into something like a structured and sustainable system. So what we did, we came down to the so-called ECI shortlist of 88 indicators. Yeah, and a big part of our work is now basically to tell everybody who is interested in comparable data at European level that there are these 88 indicators where we actually try to make sure that they are really collected at good and comparable quality, and that they are available also in the long term. We collaborate on that mainly with Eurostat. And at the same time, so we try to promote using those indicators if you want to measure anything in health. On the other hand, we try to say, do not develop new indicators unless you are really sure that those indicators there can't actually do the job. Yes, and that is a quite difficult task, I have to say. In the end, everybody understands the logic and rationale behind this policy, but it's very, very difficult to implement, because people then say, yes, but for, say, diabetes, we need more specific indicators to really measure our policy. And so we are not the most popular people there in Sanco, because we always try to restrict the number of indicators, saying if we define more and more, we will never have the data in the end, and that's not going to help in any case. And of course, what we indeed actually try to do is, with these 88 indicators, cover all health themes in a broad way. Yes, that's all on our website, so if you are interested, you can look at what specifically we have there. And of course, indeed, the added value is that they are well defined, and the EGI group, essentially, so this expert group on health information, discusses the definition of these indicators together with Eurostat, and so as they are collected in a harmonized way that allows comparison. That's not really true for all 88 of them, but we are working on further implementation of these indicators. Yes, and this, as far as we are concerned, is basically the embryo of our future integrated and sustainable health information system, those 88 indicators. And here you see what areas we are covering: services and health care, aging and population, health determinants, diseases and mental health, and also health in all policies. Because, by the way, health in all policies is important, because the treaty, the EU treaty, actually prescribes that in all policies a high level of health protection should also be an objective. Yes, and we of course also have the ambition to measure that for all the policies of the European Union, and you can imagine that's really pretty complicated to do that. So that will take a couple of decades, I guess, until we really can do that. But at least we have a start with a couple of indicators here. Yeah, and then of course we collaborate with all the relevant data providers and other people active. Yes. So Eurostat obviously is our most important counterpart, the JRC of course as well, and maybe I should say that we now try to improve our cooperation on public health with the JRC substantially. We have, for example, an agreement with the JRC to coordinate the collection of cancer data in the European Union and the data on rare diseases in the European Union. Yes, so. We also, for these specific sorts of data, we try to achieve more sustainability by collaborating with a permanent service of our own institution, if you so wish. And in the past, this was all done by projects, and we had a real sustainability problem here. Yes, and now the problem, if you want to do something in the long term, and actually for the health data, and I guess it will be exactly the same for other environmental data, what you're interested in is not so much a snapshot of the situation at a specific moment, but you want to follow the trends. So you want to see where problems develop, and also you want to see whether the policies you implement actually achieve the objectives they have. And for that you need some long-term surveillance of the situation. And the problem with the long-term surveillance is that this is not really compatible with the funding mechanism which we have at the European Commission, because we are all bound by the financial regulation when we spend the European Union budget, and that basically says that most of the money is spent in terms of either service contracts or grants. And for these service contracts and grants which are given to third parties, they all are supposed to have a beginning and an end. Yes, so we are supposed to finance things which are one-off exercises, which keep their value by delivering a product once. Yeah, as soon as you have something which actually then needs a follow-up, you have immediately a problem if the follow-up is not something new, but just the continuation of an existing activity. And when you talk about the collection of data, it's actually a continuation of existing activities. And there in the past we had severe problems already, for example, in the collection of data on communicable diseases. Where we had, for example, organized the surveillance of HIV and tuberculosis in the European Union by projects. And at a certain moment, our auditors were telling us this cannot continue because this is obviously a permanent activity and therefore it's not fit to be funded by one project after the other. And then we had to stop surveillance of HIV at European Union level. Can you imagine that? And the solution for that was the creation of the ECDC, the European Centre for Disease Control in Stockholm. They now collect on a permanent basis all the data on communicable diseases. Now, the creation of the ECDC was made possible by a political push which developed after the SARS crisis. You know, the SARS virus, which was in 2003, which appeared in Hong Kong. And that provided, everybody was so afraid that this provided the political momentum to create the ECDC. Now the ECDC is limited to communicable diseases, and for all the other health data we do not have this kind of institutional solution. Now we then have developed the idea, as there is no political possibility to, let's say, create a new agency, expand the scope of the ECDC, give everything to the JRC, we looked around for other more permanent solution, and we came up with the idea of an ERIC, the European Research Infrastructure Consortium. That is a legal basis which was invented by our colleagues of DG RTD, so the research DG of the European Commission. And it allows the creation of something like a virtual institute which consists of institutes in member states or parts of those institutes, and which creates a joint legal entity under European law. So essentially you have really something like a virtual institute. This needs to be financed by the member states, yes, which is very difficult to achieve these days because many of the member states don't have money because of the financial crisis. But we do actually think that the advantages of having such a structure, which is fully member state driven, by the way, yes, so it is independent from the Commission and other European institutions, we think it is such a convincing idea that we hope we can persuade member states creating such a thing despite the financial crisis. And this is a process which is ongoing. The Commission can't do anything about it except waiting for some member states submitting a proposal, and that's what we hope they are going to do rather soon. And then we hope that we have such an IRIC on health information. And this IRIC is basically can be immediately active in all the member states, including in those which do not formally participate in it. It's a legal personality recognized in all member states with all the advantages which go with it, and it's not bound by the financial regulation of the European Union, which makes it much more flexible, actually also in terms of basically selling services and accepting money from third parties, which is also a very important element in the sustainability, that you do not depend only on public money these days. Now, I told you already about the rationale. Essentially, the idea is that member states can agree on which kind of health data they would like to have on a sustainable basis, comparable at European level. They can define the indicators. They can ask for money for the implementation from whatever EU program they want. Yes, the IRIC is totally flexible. So it can ask money, say, from the environmental field, if you so wish, from the health field, from the research field, from employment, for example, because the social aspects are also important there. And it is able to sell certain services to third parties and also get money from there. And all in order to develop those health indicators they think are necessary at European level. What such an IRIC could also do is be a data repository for all those data which are still created by projects, because there will always be projects generating data for health. And as I said, these days there is very often the problem they create databases, and then these databases after the end of the project cannot even be hosted somewhere. And we would like to have this IRIC also having this functionality of hosting data. And one element to start making the link to environmental data is that when we had our first discussions about the IRIC, member states actually agreed that also the question of biomonitoring, so in other words, the presence of chemical substances in the human body, which might come from all sorts of sources, including environmental sources, that this merits some continuation and sustainability, and so that it is considered that biomonitoring might be part of this, the activities of this IRIC. Yeah, and if you are interested in the details, we had some preliminary discussions about this IRIC, and those are the areas which were identified as priorities by the member states. There's a scoping paper on the website of DG Sanko, which you can download and read all that. I'm not going to go into the details because I should respect more or less the time. Okay, now I also want to explain to you why we think when we construct our sustainable health information system, why we think it is important to also collaborate with the INSPIRE framework. Because when we talk about health data, I mean, traditionally there was already a spatial element always included, if you so wish. Yeah, because what we call health determinants, what determines the health outcome, is in very many cases localized. And therefore, if you create such a new system, yeah, and possibly such a research infrastructure which takes up working maybe at the earliest, we could expect 2017 or 2018, then we would like right from the start that all possibilities to link health data with geographical data are used. Yes, and that's why we are interested in starting to look around, and in particular collaborating with Inspire right from the start. And just to give you some examples of issues which we are facing, which we have been facing in the recent past, where this is very important. We are just in the process, our scientific committee, SKINIA, I don't know if you know that, they are basically evaluating new risks, and they have the task to update an opinion on the health effect of electromagnetic fields. Basically they do that every 5 years or so, and now we have just a draft opinion in public consultation, and we received lots of comments, as you can imagine, on that. But it is quite obvious that if you want to do a scientific assessment of the effects of electromagnetic fields, many of these fields are essentially localized, yeah, like power lines, for example, or Wi-Fi antennas or mobile phone antennas. And of course, therefore it is important for a proper scientific assessment to have good geographical data on where the people live who are affected and where actually the sources of radiation are. The same applies also for infectious diseases. I mentioned already that infectious diseases do not respect borders, and as basically if they are contagious, yes, you need to know where you got the contagion. So if you want to follow the path of an infectious disease, how it spreads in the population, also there it is actually important to have good geographical data as well. Yes. Now, as you can see, we are just in the process of trying to bring some more structure into this very vast field of health data. And in this process, we indeed are very interested in linking this process with the Inspire framework in order to have a good link with geographical data and also other data to facilitate both political decision making, yes, in the area of environment and health, but also possibly new research insights, which is also very important for future health policy. Yes, I think I leave it there. So thank you very much for your attention, and if you have any questions, I'm happy to reply to your questions.
So thank you, Mr. Streck. Anyone has any burning question? We will be having a round of questions after.
Thank you very much for this interesting presentation. My name is Virginia Estevez, and I'm responsible of the GIS system at the European Centre for Disease Prevention and Control. It has been really illustrative, and I just have two small comments and one question. One comment is that I think that our both institutions are doing a lot of work jointly. I know it from my colleagues directly with rapid risk assessments, etc., with your staff. And I can tell you also that ECDC has contributed at the level that we are able to do it to make a sustainable use of some databases that, as you mentioned, are coming from projects that end up and nobody knows very well what is going to happen with this data. This is happening with the European Environmental and Epidemiological Big Data Sets full of environmental data called E3. coming from the project Eden that is hosted now at ECDC with more than 900 different environmental data sets between imagery, a series of data, etc. Together with this, I have a question for you. I've seen that DG Sanco is coordinating together with member states the kind of data that they are going to provide, and also the kind of indicators that they want also to provide to you in order to manage public health data. But which is the role of organizations like us who are also dealing with member states? Is there any kind of coordination from your side regarding to us? Because we are also collecting this data. We have a huge database for epidemiological data. In total, we are monitoring 52 infectious diseases at ECDC. And I think that from your words, I was a bit worried because I think that there is not so well maybe coordination between what you are requesting from member states, because somehow we are doing also the same work. We are meeting with them on regular basis at ECDC. So I would like your opinion on this. Thank you very much.
Yes. So as far as the ECD is concerned, of course, we consider for infectious diseases the problem is solved. So we are not making any other efforts on infectious diseases. Just we try to link up with the ECDC as much as we can. And that is, for example, that applies also to Eurostat. There's an agreement between Eurostat and the ECDC that, of course, Eurostat is not going to collect any further data on infectious diseases either. What we essentially try, for us, the ECDC is one of the organizations which are in charge of collecting the data, and an ECDC representative is always part of our IGI group, which I mentioned, our expert group on health information. So essentially, for the communicable diseases, we have already an institutionalized solution, which just needs to be linked up to all the activities as far as relevant. For example, just to give you one example, there in many cases, infectious diseases are actually causing cancer, and that's why you have then to ensure a close collaboration between the data on, say, hepatitis, which are collected by the ECDC, and the data on liver cancer, because that is, and the same applies for human papillomavirus and cervical cancer. And therefore, what we do is actually to link the ECDC directly with the activities which are ongoing in those areas. Yeah, and in a way, it's the same. We hope to have the same situation now for cancer data with the JRC. Yes, where the JRC essentially will be in charge of collecting the data at European level, and then we will also not further finance any other activities in that area of cancer. Yes, that we hope then is also an area where this problem of sustainability is being solved. Yes, and we are, of course, the ideal situation would be to have one big institute doing everything, but unfortunately this is not a realistic prospect at the moment. So what we try is to use our IGI group to link the different activities at European level. And by the way, not only at European level, also beyond, because also OECD, of which several EU member states are collecting data on health, and also WHO is collecting data on health. And also OECD and WHO are represented in our expert group on health information, so that we don't have overlaps.
Yeah, there's and exactly on that, I think this is exactly when you have this kind of diverse landscape of data providers, and that may be in its good right that you have all these providers. That's indeed where Inspire can help you, because this has this distributed notion. So if you are able to roll out in a partnership, and this is a governance thing, with them this approach to work with Inspire, then you get an infrastructure which you can use to bring things together. I think that would be very beneficial for you. And I just wanted to make, because you said this naming of shaming of countries, it's nothing you can do on data. I would like to give you the experience from the European Environment Agency. We have been investing, of course, in our network and in good relationship and trust and so on. But now all the environmental data they are sending to us, there we have a system of smileys and frownies, and they're actually appreciating this. As long as you have a process where you agree with them on criteria, you can indeed do that. You can say, hey, Austria, you're doing well this year on that, or Denmark, you're not doing well and you have to improve. People like to have this kind of evidence to get things moving. So this is just an encouragement.
something there. I just need to say thank you very much for this comment. And indeed, we try to work in this direction and convincing member states that it's actually beneficial to have comparable data for them to improve their systems.
Thank you for this presentation. Wolfgang Steinmer from German Space Agency. I would like to hear a bit more on the geographic aspects of data use. You certainly have heard of this famous example of the Dr. Snow in the middle of the 18th century who related causes of cholera through geographic means. What did he simply do? He mapped the occurrence of cholera, the houses where they occurred, and he mapped potential sources, the wells across London, and he could find a relationship. So the causes were identified through geographic means. So what you would have to do, you mentioned that you map potential threats, potential sources in the form of EMF, for instance, but you must also map, of course, these 88 indicators across Europe in order to relate them to potential natural risks or local protection systems and so on. How far does the initiative go in that way?
I would say as far as it gets. Yeah, that depends basically on the data source. If, for example, you get your data through the national statistical systems, yes, they are, of course, very well defined at national level, and it's also very well defined down to which level of geographical granularity you can actually go. Of course, we try to harmonize that. We try to identify where this is particularly important, but this is very difficult because there is a difference between whether you need those data for political decision making and just want to measure basically whether your policies are successful, and for that normally such a high granularity is not necessary, or whether you need the data for research, like in the area of EMF. Then of course, in order to have really credible results, you need a rather high level of granularity. So that all depends on how we identify the objectives. Yes, and in a sense, we need to advance much more in identifying the objectives we want to reach with certain data sets in order to make decisions on that. Yes, for the time being, it's more generally speaking that we would like to have geographical information associated as a principle. Yes, so that it gets part of the overall development routine, if you so wish.
Okay, due to time constraints, any last question?
Thank you. My name is Martin Seiler from the Coordination Office of the Spatial Data Infrastructure in Germany, and I wonder if you have looked at the data specification of the Inspire theme for human health and safety, and whether this data specification is actually fit for purpose, for your purpose. Thank you.
Yeah. This is something we should look into in the future. But as I said, the problem is defining this fit for purpose. Yes, in order to be able to say that something is fit for purpose, you first have to define the purpose, and that's in a way the process we are in, defining that purpose. And of course, what I can say generally about that, it is very easy to collect some experts in a room and ask them to define what kind of data specifications would be the best ones. And in the past this was actually done quite often. The problem is, if you do that without asking the users who are actually making use of those data, be it researchers or be it political decision makers, then this remains pure theory. And that's why we don't want to repeat this kind of exercise. We are trying to work more politically first to ensure that actually people understand the value of comparable data at European level in general, because that's the first step. And then, once they have basically accepted this idea of having comparable health data at European level, then we start discussing, okay, now for what specific purposes do you want to use those data, and what kind of data specifications do we need in order to achieve this purpose? Yes.
Thank you very much for your answers and your questions. We will have a chance to go back to these questions again. And now, please let me invite Mrs. Hin-Yan Liu, who is working in the Norwegian Air Quality Institute, and she will give us a presentation about the risk assessment and the instruments that are used for these.
Thank you. Okay, good morning. First, I would like to thanks Jerry for inviting me come here to present our knowledge and experience on this topic. My name is Hin-Yan Liu. I'm from Norwegian Institute for Air Research. My work at the institute is mainly linked to the environmental exposure assessment to the air pollution coming from traffic. So, what I'm going to present, first I will give a short summary about what is environmental health risk assessment. Then I will introduce a few examples, like what toolbox, the methodologies we use to do the environmental health risk assessment, and what data it requires by using such toolbox. Third, I will present the challenge we might based upon our previous project, and also the development need. First point is I would like to give a short introduction about 2 EU-funded project, which is highly linked to this topic, and at the end I will have a few points with the conclusions. So, what is environmental health risk assessment? I guess most of us we know that. Actually, it is a process of estimating the potential impact of the environmental hazard. It can be chemical, it can be physical hazard, it can be biological hazard. On a specified human population, it can be on the individual, can be on different genders, women, children, elderly, or can be on a vulnerable group. Under a specific set of conditions, like certain situations, certain locations, for a certain time frame, sort of how long you are exposed to such environmental hazard, and what concentration of such hazard, environmental hazard, and then what health response. There are different types of environmental health risk assessment. It's really depend upon the purpose. It can be individual risk assessment. It's very different. Some people are more tolerant. Some people may more sensitive for certain environmental hazard. It can be population level, and it can be quantified. You give the certain numbers to show certain level of health risk, and you can at some situations you can, maybe it's difficult to quantify it, but you could describe what potential health risk you may have if you live in such situation for certain time. There are sort of general procedures when you do the environmental health risk assessment. First, you need to know what you are going to target it, what issues. Then you need to sort of follow this DPSEA framework, what is drivers, and what is pressures, and what is the status, how people exposed to such environmental hazard, and what is the health effect, and what is the actions, the policy related. It certainly is a multidisciplinary field, since the environmental health is linked to the environment, health, and epidemiology or toxicology, and policy science is quite, I would say, it's really complicated topic. Toolbox. In order to do the environmental risk assessment, we need certain methods. There's no consistent definition. What is environmental health risk assessment toolbox? So we gave the first definition in one of the EU FP6 project called HAMINET. It is Health Environmental Network. We see it can be defined as any tools, any guidance, procedure, software, or steps or protocols that can be used to support the environmental health risk assessment process. Under this four, just a screenshot to show they are all type of toolbox. So what data, information do we need in order to do environmental health risk assessment? It's very simple. The data we need is follow this the 5 key steps in the previous slide. We need the environmental data. We need the exposure dose. So how much exposed? What dose you exposed? And then you have a health response. What is your health risk? And what is impact on your health? In order to do the environmental health risk assessment, in addition to this essential data, we also need sort of background data. Since, for example, the environmental hazard or air pollution, for example, across Europe, it is different. Location geographically is different. The sensitivity level of the population are also different. Background, socio-economic is also highly linked to the environmental hazard, and also the health status, your mortality, mobility, your family health situation. So there are many projects. They are trying to gather an existing toolbox that we can use to assess the environmental health risks. So, for example, there are 4 or 5 FP6 projects. One of the main goal is to gather such toolbox. There is also one project, the FP7 project. They are all linked to the air pollution from traffic, of course. One is the FP7 project Transform. It is the first project gathering toolbox to assess the population level of the exposure to the traffic air pollution. This figure is a screenshot of the FP6 project called Interesa. It is a very big and integrated project we used for years to gather in such toolbox. It is very nice. If you click this web link, you can get into the system. You see what is toolbox in this domain, environmental health domain, the guideline, the procedure, how to do that, and what methodology you can use, what data is available from where, and there is also examples you can test by a certain type of methodologies. This is another screenshot. It's kind of similar like the previous one I present, the 5 steps. It's kind of you follow the procedure when you are planning to do the environmental health risk assessment. So what challenge we met based upon this 4 or 5 FP6 project? We did sort of review for the existing environmental health monitoring program. We try to collect data which can be used or compared across Europe. So the challenge is like, I guess we all know that, as data fragmentation of the data set, lack of harmonization, sometimes language is a big problem, data quality. In practice, how to access to the data. Environmental data, probably that's not big issues, but it is very difficult to access to the health data, since some of the health data linked to the ethical problem. When we do the integration of data, it's also face problem because many of the database, they have different data format, and we have a problem to understand their data property and data pedigree. But we tried to analyze each database, extract the data which can be added value. You can compare certain level of database across Europe. So what we come out, it is worthwhile to collect the existing data to help compromise the data generated from the project we are having. But we strongly suggest if there is possible to do the environmental health monitoring in the future, we suggest integrated, systematic approach. Do the monitoring is not only monitoring the environment, we address environmental monitoring, health surveillance. It's also ecosystem surveillance by monitoring. These 4 types of monitoring, they are highly linked to the environmental health risk assessment. You can't have each monitoring system individually. It's best they can sort of top-down approach. They can have same or a similar approach that can be the data generated from different type of monitoring can be used in a later stage. However, if there's not possible to do the such monitoring, environmental health monitoring, since it is very expensive, if you are going to collect existing data, we also suggest a few procedures. You need to first you need to define why you want to integrate existing data. Then you collect each database. Before you integrate each database, you need to analyze each database and transfer database format into the common and sort of minimize the differences and maximize the similarity. Then you integrate them together and then try to get some information that can be used by different users and stakeholders. So, what we sort of discovered the future challenge in this field, we address citizen science and the citizen observatory can be the future direction. Since we all know the traditional approach, we do the environmental health risk assessment. It's kind of researchers, and at certain level we involve policymakers. However, citizens, they are the passive information receiver. It's like you transfer information to them. Okay, this is a very important problem. You need to pay attention. You need to do this, that. Maybe the citizens, they don't really pay attention. But if you involve them in such a program, let them play some role, then they will probably pay it more seriously, and they understand what is exactly environmental health risk, what is environmental hazard and human health. In this way, it's very often we do such risk assessments for the scientific purpose, and also try to establish a dialogue between researchers and the policymakers. However, we need to know the information we provide to the different type of stakeholders, which is useful. For example, information you provide to the general citizens is really useful for them. And on the other hand, if we involve citizens in such a monitoring program, they may provide the information in a traditional way we cannot collect. And it is also, we can get location-based information, for example, community-based environmental health information. Currently, for example, smartphones and low-cost sensors, low-cost, for example, air quality sensors, and also ICT, information communication technologies. It's easily, we can involve the citizen to participate in such monitoring program. In a way, it can increase the data at both time resolution and spatial resolution. So what data we need in order to do environmental health risk assessment? Of course, for the regulation for scientific purpose, we need high air data quality. I just give the example from the air quality data linked to the health. We have monitoring air quality monitoring stations in each city, but the number is limited because it's very cost. So the data generated from air quality monitoring station, it is very high, it's very accurate. However, the spatial resolution is not high. In order to have the high time resolution and high spatial resolution, it is possible to install the microsensor, low-cost microsensor. But the challenges like data generated from the low-cost microsensors is not that high compared to the traditional data. The data generated from traditional large air quality monitoring station. So how to combine or compromise these two put together in a way reduce the cost and also serve a certain purpose. For example, the data from we can install very high, very high density, low-cost air quality sensors in the cities. Now you get the data generated. Even it's not that accurate, but all the data all sensors they follow the same trend compared to the data generated from traditional air quality monitoring station. So this link to the two EU FP7 and the EU DJ Interprocess project we are running at NILU now. City Science is community-based citizen observatory for improving quality of life. We have 28 partners. We have case study in 9 cities across Europe. We monitor both outdoor and indoor air quality, and also the environmental quality in public space. The goal of both of these projects try to involve citizens to test this approach if it's durable, if it makes sense, and also in a way to raise their environmental awareness, increase their quality of life. Here is the approach. How are we going to do that? We mounted, of course, we have the air quality sensors. No, and we have all air quality monitoring stations in these 9 cities. Like in Oslo, we have around 20 air quality monitoring stations. Then we make them like a background data. We also mounted the microsensor glucose on the bus. We monitor the air quality along the bus line. We mounted sensor on the electronic bicycles. We monitor air quality along the bicycle line. And we also ask, for example, in Oslo, we ask street polity. They walk around the cities to check if car parking is illegal. Or, so they walk all the time, everywhere in the city, so they carry a sensor when they go out. We mounted static sensors in certain location in the city. We mounted sensor inside the school and outside school. We even mounted sensor in certain like individual house outside their balcony, and we show the data when it's best time. You can open the window, for example, in school when it's best time. They can let children and they go out to play. So all this except the hardware we provided, generate data, we also collect data like a citizen or public, their volunteered information. Scan when and where, what they feel. They feel coughing, they feel dizzying, and they feel vomiting, and what they see, traffic, etc. They can upload such information through the mobile app we developed in the project. So all these different types of data, they through the Wi-Fi or through a GPRS transfer to the project data center. Then in the database, we extract data and then we do data analysis, data fusion, and data visualization. We provide a different outcome toward different stakeholders. For example, we have a different outcome toward the researchers. We have different products toward the policymakers and products toward the general public. As required, we need to make data generated from these two projects, and the other four FP7, like citizen observatory related projects, have to be the GEOS compatible. It's global Earth observation of systems. I guess if we make data GEOS compatible, it is also compatible with INSPIRE. But we need to check it. Yeah. So this is my last slide. What I can conclude: the technical challenge to connect this part, data sources. The content challenge: we need to provide sort of enough information or data to serve different different giving purpose. It is going to the user community. They have different needs and requirements. I have addressed the public and authority, researcher, policymakers. They have different needs. For us, it's kind of learning by hearing process. It's a benchmark examples which can help to define solutions. Even the data cannot be used for the regulation purpose, but still it covers spatial and time resolution. So thank you for your attention.
So thank you so much for the presentation. I would say now, as Mr. Schweck has shown, there is a big movement to expand health to other policies. Last November, we have seen the 7th Environment Action Program passed, and one of the three pillars of the whole policy is how the health and environment will link. INSPIRE is a major concept. It doesn't serve a purpose. To my utter frustration for many years, that there is no very specific purpose that can be shown, but it did a marvelous job of being generic yet applicable. We have data specifications now that allow the key point, and this is modeling. I've spent 20 years in decision and policy making support, and what I've learned is there's only one thing worse than using models, and it is not using models. And INSPIRE, as such, is on the way to allow a completely new approach to decision making, risk assessments, and regulatory framework as such. So at this point, I really wished in this presentation for you to see the full context of what we are going to face, and I will ask you now, what would you contribute to action that can arise after a meeting like this? If you would like to have more information, just information, if you would like to have a specific issue being further elaborated upon, we've heard about risk assessment toolboxes that are the key models used to assessing impact of, for instance, environment on the health. And if you would be interested and willing to cooperate on these issues. So thank you again, presenters, and I will leave the floor to your questions now.
Okay, thanks a lot. Okay, does it work? Okay, yeah. First of all, my name is Martin Tuchňa. I'm from Slovak Environmental Agency. On the beginning, I would like to express my acknowledgement and also appreciation that from the time when I saw when the data specification for human health and safety was developed, I remember it was relatively quite challenging process to put these two completely different domains together. I mean the health people and the geo ICT people, and also the way of understanding where both domains can see the benefits was not easy task, and therefore I'm quite happy to see that this movement has some tangible follow-up. And what I would maybe recommend or appreciate from, let's say, user point of view, I see, of course, it's important to make sure that this high level or policy level agreement is achieved on the EU level. But what would be really useful would be also to think about some really simple, not very complicated sort of evidence of implementation, to put some either EU data together, I mean health data with some spatial dimension through some simple application, just to show actually where these efforts can end up in some reasonable time span. And also somehow I would really appreciate, from the national perspective, we are in touch with some colleagues back in Slovakia who are trying to also somehow raise awareness about the potential views of geospatial content and functionality to support this kind of use cases, to somehow support these national initiatives. I'm sure these people are on the beginning, these efforts, but seeing that from EU perspective there is some sort of at least encouragement, this would give strong support to these national initiatives. So I'm sure it's a really challenging task for future, but these 2 points I would like to call on the table, and what we can offer, at least from our perspective as a national body supporting the implementation of Inspire, we would like to be sort of hub to support these national initiatives and communicate them towards this EU level and vice versa.
Hello, my name is Manuela Pfeiffer from Germany. I was member of the thematic working group on natural risk zones, and I have maybe the hint for you that we have to deal with similar requirements for the assessments, and we also have schema elements for hazard, risk. We deal with magnitude, exposure, monitoring and impacts. Maybe you can have a look at our data specification. We modeled it in a very generic way, and I'm convinced that you can make a reuse of our data model for specific purposes. And the other hint is that to expand your data collection, a quick win would be to harvest the data from the Basin Water Directive, because this is a very good data stream for you. Okay, that's it.
Okay, any inputs, expectations, like from Belgium?
I'm not a Chinese volunteer from Belgium. Well, yeah, but concerning the CitySense project, of course, yeah, I'm an air quality guy, and well, yeah, our first worry is the quality of the measurements, and we don't see any serious performance of mobile monitors at the moment. I mean, it's just the data being collected that way is just not to be taken seriously. That's a very serious issue. So that is at the moment a game breaker, I'm afraid. I mean, there is a serious test now of many mobile monitors being performed by the JRC, and well, there are some interesting results, but still, I mean, it's that is. I mean, yes, you rightly said there is a technical issue there, and but at the moment, it's still a major deal breaker when it comes to doing something along the lines of citizen sciences for air quality. So and there at the moment, well, the only way forward I see is high resolution modeling, which is performing a lot better in that respect. But then of course you have other issues of what is then actually the personal exposure and so forth. Well, actually, I mean, there are more expensive mobile monitoring devices which do produce usable data, like the mini accelerometers, but they cost like about 5,000 euros per device. So I mean, they will never be employed on a large scale. But cheaper monitors are just not usable. They not reliable enough to do any serious scientific work. I mean, most of the time there's a better correlation between the temperature of the device and the measurements than with actual concentrations. So that's just the way it is. So if you don't have any interesting results, it's very difficult to get people infused. That is at the moment a bit my worry.
For example, CO and NO quality is quite good, but for the NO2 and the PM is quite high. I would say quite high, like 20% of the accuracy compared to 20% of like hair up and down. We realize this problem. It's like your dress cannot be used for serious scientific research. It cannot be used for the regulation recommendation. But you know, we compare the data from existing sources, compare data from modelings, compare data from traditional air quality monitoring stations, and this can, for the education purpose, involve citizens. And we hopefully at the end we could use data for some other purpose. But still, at this moment, if I present data to you, you will see the stabilities, local sensor. You know, you can't expect it that very high accuracy. But this technology is developed very fast. Since in the project we have 6 sensor providers. In the way they compete each other, we use the best one at the end. Static one. If you install the sensor on the like static location, like street light lamps, it is perform very stable. But the sensor you carry it on your body, or you mount it on the bicycle, or you mount it on the bus, there's some stability problem. But this for this project, we are trying to test and see at the end if there's you know. Some useful products like the mobile apps, like we provide, for example, for the air quality, we provide air quality index to the citizens. Okay, if they want to know, okay, give me. I don't want to say the numbers, but give me the color, the figures through color. Okay, today PM, concentration is very high, and I have asthma allergy problem, and then better stay indoor. They want such instructive information recommendation for general public, since they are maybe not that expert in this field. They don't bother the data, but they want to give such information. We try also compare such information with our existing air quality warning system. It's like a weather forecasting. We give such information. It may not be that accurate, but still sometimes they give you information which is useful to protect your health. Yeah. Mm.
I have another reflection on this ambition to find out better or define better the data landscape on health. I think this is kind of the exercise when we want to make a link with Inspire. And from the air quality side, I think the data landscape is already quite visible. It has been mapped to a degree. We see areas with more or with less progress. Generally speaking, these indicator exercises, and you were reporting about that, this is useful. I mean, you said you have identified 88 indicators. Are you able to provide the data also which is needed to underpin these indicators very clearly? This is probably different by indicators. But if you are able to, in some activity, if you are able to flesh out what is really the data which is underpinning those indicators, then yes, with this you can go and you can look back at this Inspire Health data specification, see if you maybe find something there also in the other areas. But this could be a concrete activity to help paving this path to integration with Inspire, because it sounds like a long path still to go. But I think some activities have to be pursued, and Jiri was looking at what could one do after such a motivation workshop which we have here. Just an idea, which we have been doing in other areas. That's why I'm saying it on environmental data. Looking at indicators, defining the business case, and then coming from there to the data needs. Not to make it too technology driven, but data availability driven.
We sit down with Gigi and then we'll see whether something specific can be done.
Asking Mrs. Bradley to say something. They will speak German.
Thank you. I'd like to stress again the importance of the usage of the actual data specifications within the Commission, because, well, you have to think about the implications of the directive in the member states. We have far-reaching legal obligations to provide those data sets in this data specification, and it's very hard to sell if the Commission, and in this case probably the DG Health, is not using, like actually making use of those data sets. If they're not fit for purpose, we have a problem, I think. Then we have to sit down and talk about like how we can actually change the specifications to fulfill your actual requirements, because otherwise it's going to be very, very hard to sell Inspire at home, basically, and people will not be able or not be willing to collaborate on that. And in that case, if we or the Commission forces the data providers to provide the data sets in Inspire compliant way, well, it's just going to be another data flow that ends in a dead end, I'm afraid. So that'd be my suggestion for the way forward. Thank you.
Okay, so it seems that we are reaching the end of the time that we were given in this workshop. I would like to ask Wanda Lima to provide us with some concluding remarks.
Thank you, G. I fully agree, and this is the sense of this workshop, to take use of what is in Inspire data specifications, mainly what is in the regulation and what is in the technical guidelines to support the way how implement what is in the regulation, and that's the scope of what we have, the process we have in place for the maintenance of and implementation of Inspire. We have the expert group that is called MIG, with the member state representatives that are tackling through a work program the issues for the implementation and maintenance. So what are the issues still needs to be solved, improved, and let's say look for any change whenever it is of relevance. And a way of also to do this, it's what we included in that work program as what you call in jargon the activity 14, which is the cluster of the teams which want to follow up the implementation issues and the links with the real cases for all teams of Inspire. And within this cluster of teams, human health is one of them. So if how to activate those clusters, which will be through the experts on the domain that want to make part of this networking of this, let's say, group of experts that are experimenting the issues on implementing a certain team, so the data sets they have in the organizations to implement the Inspire. But we know that this is not going with the same speed for all teams in all countries, and we want to profit from the experience of the ones that succeed first, also to push the others that are still implementing according to, let's say, the priorities and the possibilities within the member state. And this is also through this cluster we are thinking to have a person which we call facilitator that share, push up and activate the activities around those teams. It can be very well an activity for that cluster that needs to start working immediately after holidays, summer holidays, to have a look how things are going within the member states regarding human health, the data that are related with this team, and to see what are how to link this with the requirements that will come from the presentation we have this morning from Mr. Schreck. This is one aspect. Of course, once we developed the data spec, they were done based on use cases and not covering all possible use cases, the ones that were considered the most urgent, or the ones that the experts on the group feels more confident to develop coherent and let's say usable data models. So not everything is there. Other things may be still developed. So the case of safety, that it's not included in the regulation because we felt that we need to have a better discussion among member states to see if what is proposed fits for purpose, and so therefore is a well advanced piece of work but not yet in conditions to be in the regulation. So this is also another thing from where to start. But I don't think we need to reinvent something new in terms of use cases. What we need is to work together with the ones which are working on those domains within the member states for filling in other obligations regarding other policy domains, and based on those real problems that needs to be solved, to see how what we propose applies and where modification needs to be done. So I think there is a fruitful field for work on that domain, and what we want is just to keep always linked from requirements to solving problems. Only a word regarding the equality. I think this is a good example. Also, we have European regulation regarding the monitoring the equality. We have data flows already well established within the member states, and that are translated also at the end with certain reporting obligations for this for several air quality related directives within the member states. Data are used coming from measurements, and Inspire make the obligation of member states to make the data from the measurements available whenever there is a requirement to use it. It's just not to get it there. So not only let's say the worked out data until get indicators or whatever, but also the underpin data that is already taken and modeled through Inspire with the teams like environmental monitoring facilities, how to use the measured data and to model it in a way that is of use for all requirements that are around. And since there is the obligation to make this data available through services, here is a clear example of how Inspire deal with those issues. So the legal frame is there. Data must be available. how to do this through service is also available through legal act, and also through technical way how to do this on member states. Of course, we are at the phase of implementation, and what we saw, the example G represent what we can be seen through the European Geoportal, gives an indication of what is already available, but not 100%, let's say. Doesn't show the full picture, because at the member state level, going through the national portals that also have been put in place using the service, also implementing Inspire, you will find much more data and service that what you can harvest currently with the European one. So just to conclude, I'm looking forward to have, let's say, more detailed proposals, examples from where to start, digging in what are the difficulties and what are the work that needs to be done to get even better use of Inspire. So it's a process. We are already well advanced on that process, and I'm very happy with that. Thank you all.
So many thanks to speakers. Very much thank you for coming, and those who might be interested, we have at 2 o'clock in auditorium 7 room available for some informal communication if you're interested in the topic further, if you want to communicate about possible actions, and so on and so on. So thank you all again. Good day.